Tennis elbow, or also known as lateral epicondylitis, is the most common overuse syndrome in the elbow, a tendinopathy involving the extensor muscles of the forearm. Clinical anatomy: the elbow joint is made up of 3 bones: humerus, radius, and ulnar. Injury is often work-related, any activity involving wrist extension, pronation, or supination during manual labour. The most prominent symptom of this is pain, can be reproduced by palpation on the extensor muscles originating at the lateral epicondyle. Medial epicondylopathy, or golfer's elbow, is mostly a tendinopathy overload injury. Flexor pronator tendon degeneration occurs with repetitive forced wrist extension and forearm supination. Etiology: concentric or eccentric loading of the wrist flexors and pronators. Clinical presentation: they'll usually complain about pain of the elbow distal to the medial epicondyle of the humerus with radiation up and down the arm. Epidemiology: so elbow tendinopathy occurs at least 5 times more often and predominantly occurs on the lateral rather than the medial aspect of the joint with a 4:1 ratio. Affects up to 3% of the population, with those 35 to 50 years old most common. Rehabbing it: phase 1, twice MM, stands for protection, rest, ice, compression, elevation, modalities and medication. Phase 2, looking at establishing full, painless range of motion, soon followed by stretching and progressive isometric exercises, and then concentric and eccentric resistance exercises are added. Phase 3, progressively overload those concentric and eccentric, slow and progressive through full range of motion.
No good? Yes, please, take me there.